Many thanks for joining our session on new services and systems of mental health crisis care, where we will hear about two studies exploring different models of mental health crisis care and ask the questions, what works, how, and for whom? My name is Steve Gillard. I'm Professor of Social and Community Mental Health at St George's, University of London, and lead one of the studies, both of which are funded by the National Institute of Health Research's Health Services and Delivery Research Programme. So why the focus on crisis care? Partly this is policy driven, with the Crisis Care Concordat of 2014 requiring a multi-agency approach at a local level to improve the outcomes of crisis care and to reduce demand on emergency departments. And because the response has been commissioned locally, reflecting the needs of the local population and existing pathways of care, what has emerged has been highly variable, with a range of new models of care operating alongside more standardised provisions such as crisis resolution and home treatment teams. So this issue of what works for whom and how that fits alongside existing care pathways are important research questions. There's a broader context here too, because we have seen economically driven constraint in the capacity of both inpatient and more recently community mental health care, with thresholds for secondary care going up. The gap between primary and acute mental health care has widened, meaning that crisis care is all the more important as a means for managing demand in the system. So as researchers, we're beholden to do research that examines the experience and outcomes as well as productivity of new models of service delivery. And now on top of this, we have the impact of the COVID-19 pandemic and disruption to crisis care at a time when the need for support for many is more acute than ever. Of course, neither of these studies were designed with COVID-19 in mind, and the pandemic has delayed some of the work that might have been presented to you today. But the focus on crisis care is now more important than ever, and elements of the research have had to be repurposed in response to the current situation, hopefully, to contribute to informing the most effective way to provide mental health care in an uncertain future. So, with all of that in mind, we're going to begin by looking at the broader picture. Dr. Nicola Clibbens and Mr. Michael Ashman from Leeds University are going to present their work to date on an evidence synthesis exploring the diversity of models of crisis care, before the team from St George's, University of London, will report on a study exploring in depth one new model of crisis care, the psychiatric decision unit. Joe Lamani and Dr. Katie Anderson will describe a service mapping study and a systematic review of similar units internationally. And Dr. Jared Smith will report on an interrupted time series study evaluating the introduction of decision units. If you have any questions, please address those to the researchers using the contact details in the slides. Many thanks.
Welcome everybody, and thank you for joining our session. My name is Nicola and I'm the Principal Investigator for MHCREST, and I'm going to begin by introducing our research. I'm going to hand you over to Michael Ashman, who is a co-applicant on the study and provides a lived experience perspective and co-chairs our stakeholder group, and he's going to share some information about our progress with that. Lastly, I'll speak to you at the end again, and I will give you an indication of our progress with the research so far, and I will talk about our planned next steps. Before I move on, I'd just like to point out at the bottom of all the slides, we've got our funder and the partner organisations that are involved in the study, including our NHS sponsor. Our study is focused on crisis services delivered in the community. These services are complex. People report finding it difficult to get help quickly and find it really hard to navigate services. Our pre-protocol PPI consultations confirmed this concern, as shown in the image on the slide. This was drawn by people who had used crisis services and gives an indication of how complex, and we compared it to something like a spider web. Not being able to access help quickly when experiencing a mental health crisis is very distressing. It's frustrating and risks longer term harm such as trauma or worsening of mental health, and can be life-threatening. Some people find accessing help in a crisis particularly hard, and report not receiving help that's acceptable to them. And this can be related to a number of factors, including the person's age, their gender, their ethnicity, a disability, or even where the person lives. On a hopeful note, crisis services are a priority for improvement, including the development of different crisis services that aim to meet everybody's needs. Developments include, for example, crisis cafes, drop-in services and text messaging, and there are others. Some of these have been implemented quickly and in response to evaluations, but this has sometimes been ahead of the research evidence, and this leaves gaps in our knowledge about how crisis services produce desired outcomes. So why this study and why now? We don't know enough about how different kinds of crisis services operate together or why they produce different outcomes. Geographic variations in available crisis services may be acceptable if those variations are designed to meet the needs of different geographic populations. However, they could suggest that there are unacceptable geographic inequalities. Good research has been conducted in crisis care in the UK and internationally, but there are still gaps in our understanding about how crisis interventions work to produce context-specific outcomes. We know that working across agencies has helped to improve the quality of crisis care, and this is evidenced by collaborations such as the Crisis Care Concordat recently evaluated by McPinn. And crisis care rests amidst an array of policy priorities, too many to mention here, but they include specifically improving crisis care, suicide prevention, improving access to psychological interventions, and so on. So in response to a complex array of policy and research and service issues, MHCREST is taking a realist approach to conduct an evidence synthesis that is going to explain, hopefully, what works for whom in what circumstances in community mental health crisis care. This slide shows a diagram of our study design. MHCREST is a 20-month realist evidence synthesis with a design informed by the work of Ray Paulson and using the Ramesses guidelines developed by Wong and colleagues. And we're very grateful for being expertly guided by Andrew Booth, an expert in realist methodology on our research team. The diagram shows the iterative cycle of reviews used to firstly identify an initial programme theory towards the left of the diagram, and then followed by a series of focused reviews and consultations with stakeholders to test and refine the programme theory. Realist evidence syntheses differ from other review types by focusing on explanatory theory. For brevity today, it's perhaps easiest to compare with a systematic review. Systematic reviews are most likely to ask questions such as, does A cause B? And may ask to what extent. A realist evidence synthesis asks, by contrast, what is it about A that causes B, and for whom, in what circumstances, and why? This is achieved by taking account of context, interventions, mechanisms, and linking these to outcomes. You will see on the diagram that this is expressed as CIMO, or CIMO. MHCREST is analysing a range of secondary data from research, policy and unpublished documents alongside primary data from expert stakeholders and interviews to develop the programme theory to explain community crisis care. The contribution of the stakeholders is an essential part of the delivery of this realist evidence synthesis and is led by Michael, who will explain how this is working.
Thanks, Nicola. Firstly, I'll describe the expert stakeholder group and its role in the research. As well as shaping our study pre-protocol, a diverse expert stakeholder group is guiding our synthesis throughout. We've recruited people with lived experience of different types of crisis service, including people who visited crisis services, family members and peer support workers. We also have a mix of professional expertise from NHS and voluntary sector crisis care, as well as a commissioner, a psychiatrist and an AMP. This participatory approach enables the study team to test theory against real-world experience. This can be challenging given the technocratic discourse of research. People needed accessible information about realist CMO configurations in order to maximize their contribution to the study. Although realist methods employ high-level concepts like CMOs, people intuitively tend to think in realist ways. Why does this work? Why does this not work? In this slide, I'll demonstrate the graphics we use to explain realist methods to the ESG. The first image shows a wilting plant recovering when it's watered. Note that it's not the water that causes the change, it's the plant's response to the water, a key point in realist causation. In this second image, further complexity is introduced. Plants need many things for health: light, nutrition, warmth, all in the right amounts at the right time. This illustrates realism's use of explanatory theories to understand causation. You might need to consider hidden mechanisms such as plant biology, chemistry, or theories of weather to account for how to grow healthy plants. I'll now share how we worked with the ESG to set priorities. Having given people some understanding of realist methods, we then asked the ESG to consider a crisis scenario in the form of a vignette describing a fictional crisis situation. The vignette contained the theoretical aspects of crisis care which were emerging from the initial stages of the literature review. The team needed to know what to prioritise for the focused literature searches. Working in small groups, each with a different mixture of experience within it, each group identified their priority theories using a Diamond 9 approach. Each group could keep, discard, alter, or add theories until they were left with 9 in priority rank order. The top priority was being able to access care urgently. The ESG members told us that if you can't access care urgently, then all the other considerations are irrelevant. Compassionate and therapeutic care, involvement of service users and carers, and culturally relevant services were also prioritised. I'll now hand you back to Nicola to talk about our progress so far.
Thank you, Michael. This slide shows a simplified image of our initial programme theory. I do think that it illustrates the complexity of crisis services and our analysis. Our initial programme theory has been summarised in the bubble on the left of the diagram in dark blue using an if-then statement commonly used in realist evidence synthesis. And this leads to the outcome shown in the dark blue box on the right. As you can see, there are many outcomes that we've linked through our first theorising. In the centre of the slide, you can see the focused review topics prioritised by the ESG and the research team. And these aim to uncover mechanisms linking the context to outcomes in order to test and refine this initial programme theory. And it's through this testing and refining that we will be able to explain how services produce the outcomes and when those are related to the context. The initial programme theory summarised here was developed following searches that were expertly conducted by an information specialist to locate existing theories and logic models of mental health crisis care. From these searches, the research team identified around 250 CMOs, not all of them complete. The research team are currently screening and extracting CIMOs or CMOs from around 100 documents in each of the 3 focused reviews shown in the centre of the diagram. And these are urgency and accessibility of services, compassionate and therapeutic care and treatment as prioritised by the ESG, as Michael outlined. And the research team also prioritised multi-agency working. As you can see on the diagram, there are 2 other areas on here: culturally relevant services and service user and care and involvement in services. And we will prioritise running focus searches on those depending on what we find with our initial 3 focused searches, because realist evidence synthesis is iterative and we tend to conduct several smaller reviews to test our theorising and do this step by step so that we can generate new ideas about how the theory is working and test and refine as we go. So the next steps for our study. As with many healthcare research studies at the moment, the coronavirus has had an impact on the delivery of the study. However, with us, we're continuing to be able to do the theorising and the literature reviews for the study. It's our stakeholder consultations and our interviews have been delayed on our timeline and may eventually be conducted online rather than face-to-face. We do, however, plan to formally evaluate our stakeholder group involvement, and we continue with our iterative focused reviews. We will be conducting interviews with UK-wide stakeholders, and these include all the countries of the United Kingdom. And in doing that, we'll be able to refine our programme theory. It is our hope that the stakeholders will be able to lead on the creation of a film about our study, and we plan to report in the spring, summer of 2021. The protocol and information about the MHCREST team are available by going onto the Prospero website or the NIHR website using the links on this slide. We've also produced a blog, and the link is there to the website so you can read that. And you can contact Michael and I using the email addresses on this slide. What would be really great is if you could ask us questions or share your thoughts via Twitter by following me using the @UniLeadsMH address and using the hashtag MHCREST. Thank you very much for listening.
Hello and welcome to our virtual presentation for today's session. In the first half of the presentation, I'll be looking at the mapping study of decision units. I'm Katie, and in the second half, my lovely colleague Jo will be focusing on the systematic review. So today I'm going to ask some questions and hopefully answer them. So first of all, pretty essential, what is a psychiatric decision unit? Why are we evaluating them? What is their scope and what is their prevalence across England? And how do they fit into the crisis care pathway as a whole? So what many of you might be wondering is, what is a decision unit? Believe me, you are not alone in wondering this. So psychiatric decision units, or PDUs, are for people to receive mental health assessment during a time of acute crisis. And these short stay units provide a kind of more therapeutic response to crisis and signpost people to community services as well. So the decision study looks at how PDUs, these short stay crisis care units, how are they organised in England and how effective are they? It's a study funded for 2 years and collaborating with St George's A&E Department, UCL, LSE and the Health Foundation. So PDUs have really been cropping up in recent years in response to the pressure on A&E and inpatient wards. Psychiatric visits to A&E are taking far too long, and inpatient wards are overwhelmed, operating above capacity. Local service use evaluations have been encouraging. The decision study is the first formal national evaluation of these types of unit. So onto our mapping study of these PDUs. So we have 3 aims. We want to find the prevalence and scope of PDUs. We want to map the activities of those units and how they are configured and what kind of care they offer. And finally, we want to see if crisis care differs between trusts with and without a PDU. So how does it fit into the pathway? So where are the PDUs? Asking this question can feel very much like asking, where's Wally? Right? PDUs seem to be called something different by every trust that has one. We have crisis assessment unit, we have assessment suite, we have crisis support unit, and these units are also not always clearly signposted from central websites. So we contacted all 53 kind of mental health care trusts in England using a freedom of information request to try and bypass some of this complexity you can come across online. So of the 53 trusts we contacted, 50 responded to our mapping survey. so a 94% response rate, not too shabby. We asked the Trust what kind of mental health assessment provision they had. 100% had some form of community-based assessment service, generally in crisis teams. It's not surprising considering crisis teams have received a lot of focus and a lot of funding in recent times. 46% have some form of hospital-based assessment where patients could not stay overnight. Now this could be A&E liaison site, assessment lounges, things like that. And 26% of trusts had triage wards primarily for assessment, where patients are admitted. And then 12% of trusts said they had a PDU. So the interesting thing here is that trusts that have triage wards, we also found were no less likely to have a PDU than trust without a triage ward. So this is surprising because both triage wards and PDUs provide overnight hospital-based assessment, but there's no association between one or the other in terms of what a trust is going to have in its provision. So it seems like triage wards and PDUs don't seem to be performing the same kind of service in the eyes of trusts. So in terms of what PDUs we found 6 in total: Sheffield, Lincolnshire, Birmingham, Coventry, Southwest London and Sussex. So really located all across England. And we found 2 PDUs in Rotherham and Doncaster and Nottinghamshire that were planned but not currently open. Now Birmingham is the most established of these, and that was set up in about 2014. That was the kind of the front runner, the spearhead of this movement. We also became aware of 4 PDUs which had been decommissioned, 1 in Leeds and 3 in Lancashire. Now this is for a mixture of reasons, including patients having very lengthy stays and an unfavourable CQC report that commented on these long stays and what they also saw as unsuitable sleeping arrangements. So the units use recliner chairs, as we shall see in a minute. And the majority of PDUs were designed to reduce presentations at ED, so 4 out of the 6 trusts we contacted said, followed by reducing A&E breaches and reducing inpatient admissions, which really fits with this idea that PDUs are really a response to the pressures faced by both A&E and inpatient wards. Okay, so moving on from where they are to how are they configured. So the maximum length of stay, as you can see in the corner there, they were all short stay, but this could vary from 12 hours for 2 of the units, 23 hours, and then the maximum for any unit was 72 hours. They were all open 24 hours a day, 7 days a week. All units had recliners rather than beds and only accepted voluntary patients. So patients can sleep on these reclining chairs. So over one patient referred to them as flying business class without the champagne. But these recliners are not considered beds at the official level. And this may be crucial, as this means that PDUs do not have a designated ward status and can refer patients for inpatient care when needed. And that would not be possible if that patient were already considered to have a bed space in the PDU. Now I mentioned in the previous slide that PDUs had actually been decommissioned. And this is what happened with a PDU in Leeds. They had ward status and therefore at the official level had beds and then couldn't actually refer people out for inpatient care. So people ended up staying, weeks in a unit that was designed to stay, a couple of days. If we think about staffing, these types of units tend to have a high staff-patient ratio, staffed by mental health nurses, healthcare assistants on the main, and they all have a kind of consulting psychiatrist attached to them. And this specialist mental health staff, combined with high patient ratios, could allow the PDUs to provide more kind of therapeutic input and perhaps personal care to people in crisis. So what have we learned? Hopefully something. So the first aim, about talking about prevalence and scope, we found there were 6 PDUs, 2 yet to open, and 4 units had also been decommissioned as well. And so, units are being commissioned and decommissioned actually in the absence of formal evidence. On our second aim, PDUs had many things in common. For example, they all had recliner chairs, they were all staffed by mental health nurses, and they were all open 24 hours a day, 7 days a week. And this is likely because they've been modelled on the Birmingham unit, which I mentioned as being the longest established. Now, PDUs clearly add to mental health crisis care as laid out by the Crisis Care Concordat. They add to access to emergency care, as all PDUs are open 24/7 and designed to divert patients away from busy emergency departments or reduce their wait at A&E, so patients can more quickly access specialist mental health crisis assessment and support. And the PDU also provides care in a therapeutic space with specialist mental health staff separate to the often hectic A&E environment. Then on our third aim, we actually found no significant difference in provision between trusts that have a PDU and those that don't. So I hope you're left with an idea of the PDU model and how it fits in to the crisis care pathway. I'll now hand over to my colleague Jo. Thank you.
Hi, I'm Jo Lamani. I'm a service user researcher working for the Decision Project. Today, I'm going to be talking to you about our systematic review. Our review is looking at short stay assessment stabilisation units for mental health patients in crisis care pathways. First, I'm going to give you an overview of the research question. Then I'm going to talk a bit about the search strategy, and then I'll talk about some of the key challenges we've faced so far during the review. So we're interested in 2 things in this review: the range of short-stay mental health units for people experiencing crisis, and we're interested in finding out if they're effective or not. Now, because these units are so new here in the UK, we're really interested in looking at similar units around the world. And because these units vary so much in terms of their configuration, we've had to actually be really specific about defining exactly what we're looking for. So the 3 things we're focusing on about the units, we're looking at units that are designed to reduce the number of admissions to inpatient mental health units, or reduce the number of presentations at the emergency department, or reduce the length of stay in either one of these places. So I mentioned earlier on that we've had some really big challenges doing this particular review. This is partly because decision units are a relatively new thing in the UK, and even in the UK they can be called slightly different things. But when it comes to trying to identify these units or these types of units in the international literature, this becomes a whole different ballgame. So when we were trying to develop our PCOS framework, we had real problems trying to define specifically our intervention terms. The thing is, we didn't want to make our criteria so tight that we ended up excluding loads of really interesting but slightly differently configured units. But on the other hand, we also didn't want to make our criteria so broad that we were picking up research studies looking at things like crisis houses or day centres, those kinds of things. So this is just an example of some of the different terms that we've come across so far. So psychiatric decision unit is what we're calling them generally in the UK. Crisis stabilisation unit, that's an American term. A PECC, that tends to be used in the Australian versions of these units. So all of these different terms can include the kinds of units we want to look at in our review. So there's a real concern and worry about missing out on studies simply because the units are called something different and maybe something we haven't heard or thought of yet. So it could be that one of the things that we could suggest once the review is complete is that these kinds of units have a standardised way of being defined, or what they call themselves, because actually that would make looking at the evidence base for them so much easier and more straightforward. And here's just a look at some of the different types of units internationally. So you can see some have beds, some have chairs. I mean, this is called a PES, and a PES is short for a psychiatric emergency service. Defining these units has been a real problem. You can see how much they vary in their configuration. Another thing we've had to be really mindful of in this review is that we're only interested in really high quality studies that show the efficacy of the intervention. This means we're only screening for studies that include a comparison or a control of some kind. Now, so far we're coming across lots of different papers that describe the characteristics of people who attend these kind of short stays, but there aren't so many intervention study papers. So we're actually expecting a really small number of full text papers to make it through to extraction stage. And there's also a slight concern that there won't be any really good ones at the end of all of this. But I guess that's partly why this review is so important, is to kind of show up these gaps. So just to tell you a bit about some of the tools we're using, I decided to use an online program called Kadima. Kadima's really great. You can use Kadima to organise and manage the systematic review process. It kind of takes you through it step by step. It's a free tool that automatically organises all of our results, and at each stage it will produce a Prisma flowchart. At our data extraction stage, we'll be using these risk of bias tools to work out the quality of the studies we've selected. So just to explain a bit about our search strategy, we looked at these 5 databases. We didn't set any language or date limits because what we were looking for was so specific. As you can see from our search string, we entered broad population terms like mental disorder or psychiatric crisis or psychiatric patient, and then terms related to the types of units we were looking for. And finally, we added some search terms around the kinds of study designs we wanted. For every keyword we entered, we also looked up database-specific mesh terms, or M-trees as they're known on Embase, just to make sure we were maximising our chances of finding papers that had been indexed in multiple ways. So this is our results. This is where we've got to so far. At the moment, we're just completing the abstract screening stage of the review. We finished our database searches and ended up with 5,012 abstracts. And after deduplication, this left us with 4,200. We then double screened 20% of these, which is a total of 840 abstracts. We calculated the inter-rater reliability score to find out if we were accepting or rejecting papers in a consistent way. Thankfully, we got a really high score of around 0.8. So we're now at the stage where we're independently screening the rest of the abstracts. And here, this is where we are. So once we've finished, both of us, and this is Katie Anderson, who's another researcher on the team, both of us will move on to the next stage of review and screen all of the full text papers that made it through. We'll then hopefully be able to do a meta-analysis of the final results. And that's it. This concludes the part of the presentation. For more information, please do get in touch with us. You can also follow us on Twitter, or you can get in touch with us on our website.
Hello, my name is Jared Smith. I'm a researcher in mental health based at St George's University of London. I'm a co-investigator on the Decision project evaluating mental health decision units, also known as psychiatric decision units, in acute care pathways. Very grateful for the opportunity to present this brief online talk for the HSR UK 2020 conference. I think this is the 4th talk within a session dedicated to the new services and systems of mental health crisis care. I'm going to talk today about a pilot interrupted time series evaluation intended to investigate the impact of opening a mental health decision unit on key service parameters in the associated mental health trust. I'm just going to switch my camera off for the rest of the talk so I can better focus on the slides. So what's the rationale behind this project? Well, it's very well established that the pressures on both inpatient psychiatric facilities and emergency departments are enormous. Bed occupancy rates within psychiatric wards are often at alarming levels in the UK. The introduction of mental health decision units were intended to improve the experience of support for people experiencing a mental health crisis, and it does this by providing a fuller assessment in a safer environment, some therapeutic input, and where appropriate, signposting to community support, thereby having the potential to reduce short-stay informal psychiatric admissions and ultimately decrease mental health presentations in emergency departments. The decision project is intended to provide an evidence base that indeed the MHDUs are effective in meeting these objectives. And today I'm going to talk about a pilot interrupted time series that we conducted to assess the impact of introducing an MHDU, the Lotus MHDU, in a single mental health trust site that was Southwest London and St George's Mental Health NHS Trust. This is a large trust that covers 5 boroughs in London with an adult catchment population of approximately 850,000 people. The one purpose, evidently enough, of the pilot ITS was to inform a multi-site ITS study, as we had 4 participating MHDUs on a range of outcome measures in the larger study. So why adopt an ITS approach? Well, the method is very well suited when randomization or trialability of an intervention is limited, such as it is with evaluations of large-scale service delivery changes, like the MHDU. It's also advantageous in the fact that one can normally collect data at many time points, both before and after the introduction of a change. And by this way, by examining the differences between those over several time points, we can remove the influence of any underlying secular trend and also control for things like seasonality or other cyclical trends, as well as serial correlation. In other words, the similarity between observations as a function of the time lag between them. What were our study outcomes? All the study outcomes for the larger decision study are presented on this slide. These are obviously key parameters associated with both acute and psychiatric hospital activity. The 4 that are highlighted in yellow are the data I'm presenting today. The primary outcome there is informal admissions to a mental health trust acute adult inpatient ward. We're also considering all admissions, the average length of stay, which remains a key driver of NHS costs, as well as the number of psychiatric liaison episodes in emergency departments. So in other words, people coming into an emergency department, presenting with a mental health concern and being referred to the liaison psychiatry team. What was our data collection and analytical strategy? So we collated data from the Mental Health Trust as a weekly series for 2 years before and 2 years after implementation of the Lotus MHDU. It opened in November 2016. During these 4 years, the study period, just for context, there were almost 6,500 inpatient psychiatric admissions in the trust at this time, and that was by 3,920 service users. About 70% of service users had a single admission during the study period. We considered the weekly number of admissions and liaison psychiatry episodes as a rate. That way we could adjust for the catchment population changing during the 4-year study period. The analytical strategy, we use segmented regression analysis, which is commonly used for interrupted time series data, and we use Poisson generalized linear models for the count data, for example, the admission rates, and we used generalized linear models for the length of stay data. For each outcome, we were really interested in 2 regression coefficients. One for the immediate change, also called a step or level change, following the introduction of the MHDU, and then also a longer term change, secondly, a slope change or change in the week-to-week trend from prior MHDU implementation to post-MHDU implementation. We also considered secondary analyses that only included people with discharge from an inpatient psychiatric ward in the trust in the last 24 months. So in other words, seeing if it had any effect on people who frequently use services. If anyone is interested in seeing the full methodology for the interrupted time series, we recently published the protocol in BMC Psychiatry. Okay, so before we look at the time series data, I thought it was useful just to have a little bit of context in terms of the numbers from the Lotus Mental Health Decision Unit. So in the first 2 years after opening, there were almost 1,500 visits made by a little over 1,000 service users. 80% of the service users visited only once in this 2-year period. A small number visited 6 or more times. The mean length of stay was 37 hours. I think about 2/3 of people stayed longer than 24 hours. And again, a small number stayed longer than 72 hours, which was a breach according to Lotus MHDU guidelines. Most service users are referred to Lotus via the psychiatric liaison team in the emergency departments of surrounding hospitals, although a significant number were also referred by the CMHT. Okay, so what happens when we model admission rates on a weekly basis over time? This graph shows the weekly rate of informal psychiatric inpatient admissions over the 4-year period. On the x-axis, you see the week numbers. You see the vertical black line in the middle of the graph representing the week when the MHDU opened. The dark blue squiggly line is the observed data for the weekly rate of informal admissions. The dark red squiggly line reflects the observed data for informal admissions for those people with a discharge in the previous 24 months. The wavy light blue and red lines, they represent our regression models where we have fitted the curves accounting for seasonality and any auto-regressive terms as need be. What can we see from this graph? Well, we see that prior to the MHDU, if we look at the fitted curves, there appears to be a trend representing an increase week to week in terms of the rate of informal admissions. Upon MHDU implementation, this appears to sharply decrease immediately, and thereafter, in the following 2 years, we see a steady decline in the rate of admissions per week. And this is reflected nicely in the statistical data here with the coefficients. And I think it's most important for interpretation is to turn our attention to the estimated percentage. And if we look at all informal inpatient admissions, we see a decrease of 20% with respect to the step change or the level change. So that implies an immediate effect of the MHDU intervention in decreasing the number of informal admissions. We also see a longer term change with the trend change, so of negative 0.5% or 0.5% per week. And this reflects that prior to the MHDU, there appeared to be a week-to-week increase in the number of informal psychiatric admissions. After the MHDU, we see a decline, so a significant change in trend. And if we look at the people with a discharge in the last 24 months and consider only those people in the analyses, we see these effects are even greater, with an almost 25% decrease when the MHDU was opened in terms of admission rates. What about all psychiatric inpatient admissions? So considering both formal and informal admissions, and these were distinguished based on the legal status of the admission at the time. When we consider all admissions, we see a very similar pattern, although perhaps not the difference or impact of the MHDU is not as obvious. Again, we see a steady incline before MHDU opened, a drop when the MHDU did open, and thereafter an incrementally small week-to-week decline in the 2 years following MHDU opening. And again, this is reflected with significant findings with the coefficients and the statistical data, except here the MHDU introduction appeared to have about an 11% reduction in all inpatient admissions. And that was an immediate short-term effect, but we also see significant long-term effect, again, reflecting the reversing of the trend, which was increasing week to week prior to the MHDU. Post the MHDU, it appears to be very incrementally declining. And again, these effects appear stronger in those who've had a discharge in the last 24 months. Okay, what about length of stay? So I took the natural logarithm of the mean length of stay, so that's not the raw number there in terms of days. It's somewhat greater, of course. I did this because it fitted the model better. Probably easier just to focus on the fitted curve lines here. And what we see there is actually, prior to the MHDU, there appears to be a steady decline in the average length of stay for those admitted to a psychiatric ward. There appears to be a jump, an increase, when the MHDU is opened, and after that, a flat function thereafter, a very similar rate across the 2 years post MHDU. Oops, excuse me. And I also want to look at liaison psychiatric episodes over the 4 years. And this graph is rather interesting because it shows a marked increase across the 4-year period, a very steady but significant increase in the number of episodes over the 4-year period. And it appears here that the MHDU didn't really have a short-term effect, and it didn't really seem to change the trend either. The trend just kept on increasing post-MHDU. Both of these graphs are reflected in the statistical data. If we go back to the length of stay, we actually see a 20% increase in the average length of stay following the MHDU, but we don't see a significant long-term change in the pattern or in the trend. With respect to the liaison psychiatry episodes, we actually see no significant influence of the MHDU either in the short term or the long term. So putting this all together, what does this tell us? What do the results that I presented tell us? Well, it seems within the context of a single mental health trust, the opening of a mental health decision unit has led to a significant reduction in psychiatric admissions. This was perhaps most obvious in an immediate change of level, so a short-term effect, which decreased by 10% when we considered all inpatient psychiatric admissions, about 20% if we considered informal admissions. But perhaps most importantly, we also observed a long-term change in the trend. And this is perhaps the critical point that whereas prior to the MHDU, we were observing an increase from week to week in admission rate, post-MHDU, there was in fact a trend for a decreasing admission rate week by week. So it appeared to reverse the trend and change that by between 0.3 to 0.5% per week. Critically, these decrease in admission rates were most evident in those users with high service use. So those people that had been discharged from an inpatient psychiatric ward in the last 24 months. It is interesting that average length of stay increased significantly as a result of MHDU implementation. This probably reflects that the number of short stay ward admissions decreased, presumably because there were less service users who were informally admitted, given that those who are formally admitted tend to stay much longer in wards than those informally admitted. And there was also very notable with respect to emergency department activity, there seemed to be no effect of MHDU opening on the number of people being referred to liaison psychiatry when visiting the emergency department with a mental health concern. Okay, so very finally, what does this tell us going forward? Well, it appears that interrupted time series is a useful way of examining the changes in rates of psychiatric inpatient admissions, but also liaison psychiatry episodes. By using this method, we can at least rule out confounding changes that might be to do, you know, with the secular underlying trend. I also thought that using the weekly time aggregation unit was helpful. It gave us a lot of statistical power to detect any effects that did exist, and the models certainly weren't improved when I tried analysing the data with a monthly time aggregation unit. However, there is further work needed. I didn't look at any acute trust data or data emerging from acute trusts in the form of 4-hour breaches in emergency departments or 12-hour trolley waits. I also didn't incorporate any known within trust service changes that are unrelated to MHDU. These have been ascertained from interviews with strategic managers and need to be incorporated into models where relevant. Ultimately, the goal here is to collect data from 4 MHDUs and then pull these individual estimates so we have an overall effect and perhaps able to compare and contrast to see what the best configuration of an MHDU might be in terms of reducing rates of psychiatric inpatient admissions. That's all from me. Thank you very much for your attention. If you do have any queries or questions, please feel free to email me directly or contact the conference website. Thank you very much.